Hello and welcome everyone to this session on Mission May revision, all images revision in anesthesia. So I am going to be revising with you the short subjects, and today the first short subject that we will be revising is anesthesia. So I hope that you guys are all able to see me and hear me well. If the streaming is okay, please leave a thumbs up. Please leave a thumbs up in the chat box if the streaming is okay. Alright, so I can see that the streaming looks absolutely fine. Yes, so let's begin our class for today. I am MBBS MD DNB in Anesthesiology, and this is the Telegram channel Let's Crack NEET PG, where I post the links to all the classes that I take. I have been taking a lot of free classes for all of you all. So currently at 10:30 PM on the special class platform, we have a routine. And every day at 10:30 PM we have free classes going on, in which we revise all the flashcard revision of the subjects like medicine and surgery for all those of you who are giving the exam in May. Now this is the NEET PG free test calendar for March. So you can see over here that in March we have a lot of free sessions that are there. So 7th, 8th, 9th, 10th, 11th, 12th of March we have all these free tests that you all can attempt. The Plus subscription on Unacademy gives you access to live and recorded classes. You can learn from India's top educators. You can compete in live tests and quizzes. You can study on the device of your choice. You can access our question bank with 25,000 plus questions. The iconic subscription of Unacademy will help you get both recorded classes from Unacademy and the live classes from Prep Ladder, as well as their notes. These are our FMG toppers. The special classes that we have on Unacademy are sort of a promo for you all to watch how the Unacademy Plus works. So these special classes are free of cost. You all get reminded about the class. You have raise a hand option, you have polls for the learners, and you can get PDF notes at the end of the class. Now we have a few of these offers going on. So if you buy 3 months, you get 1 month free. You buy 1 year, you get 2 months free. So I highly recommend all of you all to use my code Dr.Jhanvi Live. This is my code. I'm just writing it down, and you can avail of any of these offers plus an extra discount by using this code. This is the Mission INICET batch that is starting from 9th of March, that is today, and I am a part of this batch. And we also have the High Yield MCQ Marathon batch for NEET PG, Focus FMG batch, and the All Educator revision batch. This is the subscription, NEET PG subscription values, and of course whenever you use my code you get an extra 10% discount on your subscription. So with that, let's begin with our class for today. Yes, so this is the first slide that I have for you guys. I want you guys to identify for me image 1, image 2, image 3 and image 4, and what are these procedures in anesthesia that are being carried out. So they are simply going to post either the image of the instrument or the image of the procedure being done, and you are expected to identify what is the procedure carried out, what is the instrument, any specific question that comes along with that procedure or instrument, and also the complication of the procedure. So these 3 questions per instrument or per procedure I want you to identify for me. Very good, Swapnil. So Swapnil is saying that the first procedure is nothing but this is an instrument which is used for giving spinal anesthesia. Excellent. Absolutely correct. So this is spinal. I am writing anesthesia as AX. Okay. So this is the instrument for spinal anesthesia. This is also called as the spinal needle. Now another name for spinal needle is nothing but Quincke-Babcock needle. Please remember this Quincke-Babcock needle. I am writing it in the bracket over here. Now what is the instrument called? The instrument is called as Quincke-Babcock needle. How will you identify this instrument? So for identification of this instrument, see, it's a plain stainless steel needle that you can see, and over here you have a transparent hub. So why do you have a transparent hub over here? So that you can see your transparent CSF flowing out. Okay, now the specific question that they always ask about spinal anesthesia is one single question: in which space do you insert the needle? So we insert the spinal anesthesia needle in L3, L4 space, and how deep do you have to go? So can anyone tell me how deep do we have to go for spinal anesthesia? So you have your, I'm just drawing your spinal cord over here. You have your spinal cord, then you have your arachnoid mater, then you have your dura mater. So which space do you need to go to give spinal anesthesia? Anyone? Very good, Hemal. So we have to go into our subarachnoid space. So this is another question that comes in the exam. And in fact, this time they had asked a question like, to do lumbar puncture, which space you have to go? Same space. You have to go into the subarachnoid space only. Next question they had asked, what is the last structure that you pierce when you enter into the spinal space? Or what is the last structure that you enter into while giving lumbar puncture? So the answer for that was, the last structure to pierce is arachnoid mater, because you have to go in the subarachnoid space. Okay. Anyone, what are the complications of this procedure? Can anyone tell me the complication of this procedure? Ek do complication? Okay. So the main complication of giving spinal anesthesia is you are blocking the thoracolumbar spinal nerves. So whenever you block the thoracolumbar spinal nerves, you have a fall in the, you are blocking the sympathetic nervous system. So you have a fall in the BP. Okay. Remember, your parasympathetic nervous system comes from craniosacral outflow and your sympathetic nervous system comes from thoracolumbar outflow. So the complication is nothing but hypotension because of blockade of thoracolumbar outflow. Okay. So the main complication is hypotension. And the other complication can be spinal cord injury, but mostly it does not happen. But main complication is hypotension and bradycardia. Okay. Now I want you guys to tell me the difference between two things. One is total spinal anesthesia and one is high spinal anesthesia. Total and high spinal anesthesia. Can anyone tell me what is the main difference between both of them? Because this can be asked in your exam as a clinical question. Okay. So I'll draw it over here and I'll explain it to you. What is total spinal and high spinal anesthesia? So imagine this is my patient. Now, and this is a spinal cord. Okay. I know, very horrible looking patient, very horrible looking spinal cord, because my drawing is not very good. So whenever I give the spinal anesthesia drug and it spreads up to the level, now it's going to block the thoracic and the lumbar spinal nerve, but if I give too much of the drug, it ascends up and it blocks my higher thoracic nerves. Okay, so imagine it's blocking these higher thoracic nerves as well as it's blocking some cervical spinal nerves also. So because of this, my patient will start complaining of tingling numbness in the arms. Okay, so tingling numbness will be there in the arms because the cervical spinal nerves are getting blocked. Along with that, the higher thoracic spinal nerves, when they get blocked, my patient will start saying that I am getting some problem in my heart. So what problem in the heart happens? The higher thoracic nerves supply the heart. So as a result of this, there will be a rapid fall in the heart rate and blood pressure of this patient. Okay, so I have involvement of the higher thoracic and the cervical spinal nerves causing tingling numbness in the patient's arms, and also the patient is having a rapid fall in heart rate and blood pressure. Okay, so that is what I get in case of high spinal anesthesia. This is high spinal anesthesia. Now what happens in total spinal anesthesia? So in total spinal anesthesia, my drug ascends right up till the brain, up to the base of the brain. So it involves the brainstem also. So what is the brainstem? The brainstem is nothing but the medulla oblongata. Now the brainstem has the respiratory center and it has the cardiac center. So both of them get blocked, and as a result of this, my patient stops breathing because the respiratory center is blocked in the brainstem, and he has sudden cardiac arrest because the cardiac center in the brainstem is blocked. Okay, so that is called as total spinal anesthesia. So high spinal anesthesia spreads to upper thoracic and cervical spinal nerves, and total spinal anesthesia spreads up to the brainstem. ठीक है, तो उतना याद होना चाहिए. So in the exam, they will give you case scenario. Patient is having sudden fall in BP, hypotension, and tingling numbness in arms. Answer: high spinal anesthesia. Patient is suddenly having cardiac arrest and and the respiration has stopped. Then that is total spinal anesthesia. Okay, everyone understood? Please leave a thumbs up in the chat box if you all have understood this concept. Okay, Hemal is having a very good question. She is asking how to reverse the high or the total spinal anesthesia. So the first thing you do is, now usually when I give the drug and if I make the patient head low, the drug spreads towards the head. So to avoid that, what I do is I prevent this head low and immediately I make the patient head up, okay, so that the drug does not spread up any further. So that is the first thing I do. I make the patient head up. That is सबसे important. Second thing that I have to do is start the patient on vasopressors. Give atropine if there is bradycardia. Give noradrenaline, adrenaline if there is fall in blood pressure, and give IV fluids to reverse the hypotension. Okay. And if the patient stops breathing completely, saturation is dropping, then I have to intubate the patient. After some time, apne aap all the symptoms will go away as the drug gets reabsorbed into the system and metabolized. But at least till the time that the patient is unstable, I have to take care of his ventilatory and hemodynamic parameters. Alright, okay. Alright, so identify picture number 2 over here and tell me what is this called as. 2 and 3 are similar, so I want you all to identify 2 and 3 for me. Two and 3 are similar, so can you all identify 2 and 3 for me? Very good, Swapnil. Excellent. So Swapnil is saying that 2 is a, now 2 and 3 समझ में है, anesthesia kit नहीं है, but 3 is an epidural needle. Yeah, can anyone tell me what is the full form of an epidural needle? Or the other name of an epidural needle? Like how you have spinal needle का name as Quincke Babcock needle, वैसे epidural का नाम क्या होता है? Okay, so the name of epidural needle is Tuhi needle. Okay, Tuhi needle. So can you guys tell me, in Tuhi needle, so the name of epidural needle is nothing but Tuhi needle. Okay, now how do you identify the Tuhi needle as compared to the spinal needle? So as you can see over here, first thing is you are getting an alternate light and dark marking in this needle that is not seen in the above spinal needle. And one very important thing that you can identify over here is you have presence of a flange or wings. Okay, so you have presence of this flange or wings on the Tuhi needle, which is not present on your spinal needle. Alright, so that is how you identify between the two of them. Now the question that they ask in the exam, to reach into the epidural space, what is the last structure to be pierced? When you want to reach into the epidural space, what is the last structure to be pierced? Anyone? Can you tell me last structure to be pierced when you have to enter into the epidural space? Yes, very good, Dr. Swapnil, absolutely correct. So this is one of the questions that comes again and again in the exam. Ligamentum flavum is the last structure to be pierced. So if you come from outside to inside, you will have your VAC skin subcutaneous tissue, and then after the subcutaneous tissue you have supraspinous ligament, interspinous ligament and ligamentum flavum. Once you pierce the ligamentum flavum, you get a loss of resistance and you reach into the epidural space. Alright, so one of the important things that they ask is again, what is the complication of epidural anesthesia? Same complication as spinal anesthesia, both of them can cause hypotension, okay, because you are blocking the sympathetic spinal nerves. Alright, so now I know I am coming in your way, so I will try to move away. Look at picture number 4 and identify the procedure that is being carried out. I don't know which side I should move, but I think this side will work. Picture number 4 and identify what is the procedure being carried out. You can see the bum of a pediatric patient and there is a needle that is being put into the upper part of the gluteal cleft. So do you know what they are trying to do in this case? Any idea? Anyone? It is a type of regional anesthesia only. No, it is not sacral anesthesia. It is in fact a type of USG guided central neuraxial blockade. Very good Hemal, very good Swapnil. Okay, so this is called as caudal anesthesia. This is called as caudal anesthesia. Okay, yeah. So in caudal anesthesia, what do you do exactly? So in caudal anesthesia, you have basically on the upper part of your gluteal cleft, that is the end of your sacrum, you insert the needle and you give the drug from there. So where does the drug spread? So suppose I am giving, this is the end of the spinal cord. Okay, so from here I am giving the drug. This is called as cauda equina. So the drug spreads in the sacral spinal nerves, as you can see in the picture, and it blocks mainly the lower thoracic, the lumbar and the sacral spinal nerves. So if a child is undergoing surgery of the lower limb, then you can give this type of caudal anesthesia for pain relief in the child. Okay, so now the thing with caudal anesthesia is that you can give it only up to 8 years of age. This is what they ask in the exam. Till when can you give caudal anesthesia? Only up to 8 years of age. Why? Because here, as I am showing you over here, as I have marked over here, there is an opening in the end of the sacrum that is called as the sacral hiatus. Hiatus means opening. So that opening is there only till 8 years of age. After 8 years of age, it fuses, so you can't put any needle in that. Okay, so caudal anesthesia can be given only up to 8 years of age. Just remember that, 8 years. Okay, alright, moving on to our next set of pictures that I want you guys to identify. So can you quickly tell me picture number 1 and picture number 2? I just want to know from you guys if you can identify these instruments and tell me these instruments are used for what procedures in anesthesia. Quickly identify the instruments. Tell me for what are these instruments used in anesthesia. Anyone? You can see the first instrument is being used to locate the brachial plexus. Can you see? With this pen you are locating the brachial plexus. With this needle you are inserting where you have located the brachial plexus. And this one is very obvious. This is an ultrasound machine. Yes, very good. No, staphylococcus. This is, your answer is incorrect. But Swapnil, your answer is correct. You are trying to find the nerve with the first one. So this is called as a peripheral nerve locator. Okay, this is called peripheral nerve locator. And niche, what you are seeing over here is an ultrasound. Both of them are used to locate nerves. The main work they do are they used to locate nerves. And for what do we try to locate nerves? We try to locate nerves for giving regional anesthesia. Now what do you mean by regional anesthesia? So as I always teach in your anesthesia classes on Unacademy, there are 3 types of anesthesia. You have general anesthesia, in which the patient is completely unconscious and he is sleeping and he does not remember anything about the surgery. Second is regional anesthesia, in that only the part getting operated, like suppose the hand has to be operated, so the hand will have no sensation and no motor power. Or if the legs have to be operated, then everything below the waist will be anesthetized, but the rest patient will be awake and conscious. Okay, so that is called as regional anesthesia. You are blocking only the region where the surgery will be carried out. And the third type of anesthesia is nothing but MAC. MAC means monitored anesthesia care, in which you are only going to monitor the patient and if required SOS, give sedation to the patient. So please remember this, guys. If you have any options in the exam as what are the types of anesthesia, so you have general anesthesia, regional anesthesia and MAC. Okay, now both your peripheral nerve locator and the ultrasound are used for helping in regional anesthesia. Again, moving my big head a little bit, there are 3 probes in ultrasound that you guys should know about, because ultrasound is one of the most important new advances. Even though it's not new anymore, but recent advances they will ask you. So there are 3 probes. The linear probe will help you find all the superficial structures. The curvy linear probe will help you find all the deep structures, and the phased array or the 2D echo probe will help you find everything about the heart. This is used for doing 2D echo of the heart. Okay, so you should just know the names of all these 3 probes. Okay, so now moving on to some of our drugs used in anesthesia and quickly revising about them. So can you guys tell me, I'm showing you 2 drugs over here. Can you tell me the class of anesthetic agents that these drugs fall in? Identify the drugs, tell me the class of anesthetic agents that they fall in. चलो कौन से 2 ड्रग्स है ये बताओ. Very good Hemal. So you can see what drugs over here. You can see propofol over here. This is propofol and this drug is ketamine. Okay, so they fall in which class of drugs? They fall in IV anesthetic agents. IV anesthetic agents. Okay, and the other 3 drugs that you can see over here are also the same. So this is etomidate and this is Thyropenton, and all of them, all 4 of them are your IV anesthetic agents, intravenous anesthetic agents. Okay, now I'm going to ask you one question and you have to tell me what is the drug of choice. Now in the exam they will ask you simple questions like drug of choice for this, drug of choice for that, but where is the small crux of the question? They will ask you what is the IV anesthetic agent of choice in neurosurgery. So you have to answer it, okay, as one of the IV agents. Then they'll ask you what is the inhalational anesthetic agent of choice in neurosurgery. So at that time they will give you options of the IV agents also. So don't get confused or don't overread or underread the question and mark wrong. You should know what drug belongs to which class and which class are they asking in the question. Okay. So for example, let me ask you what is the IV anesthetic agent of choice in neurosurgery. So out of these 4 drugs, which is the agent of choice in neurosurgery? Very good, Staphylococcus. So agent of choice, I am going to write it as AOC. Agent of choice in neurosurgery is Thyropenton. And can you tell us why is Thyropenton preferred in neurosurgery? Staphylococcus, can you tell us why is Thyropenton preferred in neurosurgery? Hemal, absolutely correct. Any reason why we prefer Thyropenton? Okay, so in neurosurgery, we want 2 things. One is we want to reduce the intracranial pressure. Okay, so that is done by all the agents. And second, the reason we want is because in neurosurgery, we can have seizures. So we have to find an agent that is anti-epileptic. So Thyropenton is the best agent with anti-epileptic properties, and that's why we prefer this. Okay. Now, if you're telling me the agent of choice in neurosurgery is Thyropenton, can you tell me which agent is contraindicated in neurosurgery? Any agent that is contraindicated in neurosurgery? Any agent contraindicated in neurosurgery, guys? Out of these 4 agents, which IV anesthetic agent is contraindicated in neurosurgery? Yes, very good Hemal, absolutely correct. So the agent contraindicated in neurosurgery is ketamine. Okay. Now why do we not prefer ketamine in neurosurgery? Because exactly in neurosurgery, as we said, we want fall in the intracranial pressure so that the brain does not bulge out. Your ketamine causes rise in ICP. So we avoid this agent in that case. Alright. Okay. What is the IV anesthetic agent of choice in daycare surgery? And also tell me what is the definition of daycare surgery. So I am giving you 4 options: propofol, ketamine, etomidate, Thyropenton. What is the IV anesthetic agent of choice in daycare surgery? Okay. So Hemal is saying propofol, absolutely correct. So AOC of daycare surgery is propofol. Can you guys tell me what is the definition of daycare surgery? Yes, very good Chakravarti. So if the patient is admitted and discharged on the same calendar day, okay, so you're admitting him today on 9th of March and you're discharging him today on the 9th of March only, then this is called as daycare surgery. Patient is getting admitted, operated and discharged on the same calendar day. Why do we prefer propofol in case of daycare surgery? Because propofol is a short acting agent it is antiemetic, it is antipruritic, and it gets metabolized quickly from the body. So the patient will have least side effects and the entire drug will get metabolized by the time he reaches home. Alright, okay. Now tell me, what is the agent, IV anesthetic agent, that is contraindicated in egg allergy? So if you have a patient who is allergic to egg, which agent should we not be giving him? If you have a patient allergic to egg, very good, Staphylococcus. So in egg allergy, the agent that is contraindicated is propofol. Why? Because propofol contains egg lecithin. So if the patient is allergic to egg, then he will have allergic reaction to propofol. Alright, next question. Which is the agent of choice in cardiac surgery? IV anesthetic agent of choice in cardiac surgery. Very good, Hemal, excellent. So the IV anesthetic agent of choice in cardiac surgery is etomidate. Okay, why? Because etomidate causes least changes in heart rate and blood pressure of the patient, and that is why, to maintain the hemodynamic stability during the induction of anesthesia, we prefer etomidate. Alright, okay. What is the IV anesthetic agent that causes emergence delirium? IV anesthetic agent that causes emergence delirium. What is emergence delirium? When the patient is waking up from anesthesia, he will be completely delirious. He will start fighting with the anesthetist, with everyone, try to wake up, hit people, or he will start talking nonsense. So that is called as emergence delirium while waking up from anesthesia. Excellent, Hemal, very good. So emergence delirium is seen with ketamine. Now, there is another thing that is seen with ketamine, and that is hallucinations and dissociative anesthesia. Please remember this term, it's very, very important in regards to ketamine, dissociative anesthesia. So dissociative anesthesia means there is out of body experience, and that is also seen with ketamine. Alright, okay. Now can you guys tell me which agent is contraindicated in porphyrias? In acute intermittent porphyrias, which agent is contraindicated? In acute intermittent porphyrias, which agent is contraindicated? Again, I am giving you these 4 agents only. All the questions come from these IV anesthetic agents and inhaled anesthetic agents only. Yes. So, contraindicated in porphyrias is Thyropenton. Okay. Now, next question for you guys is, which agent is contraindicated in adrenal gland suppression? Or if you have a patient who is very, very sick, he is in a state of sepsis and he requires steroids for maintaining his blood pressure. So in which case will you avoid, which agent will you avoid in this case? Propofol, no, that is incorrect. Patient who has adrenal gland suppression, he is septic, he requires steroids for maintaining his blood pressure. Which agent will be contraindicated? Very good, Swapnil. So it will be etomidate. Okay. Now the problem with etomidate is what? Etomidate suppresses the adrenal gland. It causes adrenal gland suppression, leading to reduced production of corticosteroids. So that is why we will prefer not to use etomidate whenever our patient is very, very sick. So if the patient is in sepsis or is admitted in the ICU critically ill, you require steroids to maintain your BP, the endogenous steroids that are produced by your adrenal gland. So we will not stop their production by giving etomidate. Alright. Okay. Next one. Next question that they ask in the exam is so case scenario, I have a patient who was walking on the road and he met with an accident, and now this patient, first of all, A, is full stomach, he is not fasting. Second, he has had a splenic rupture because he had trauma on the road and he has to be taken for emergency splenectomy. Now he has lost 2 liters of blood already and his BP is borderline. BP is 70 by 50 mm of Hg. So what agent will you use to induce anesthesia in this patient? So there are two things important in this patient. One is he is not fasting, he is full stomach, so risk of aspiration is there. And second thing, his BP is falling, so his blood pressure is 70 by 50. You have to choose the ideal IV anesthetic agent to induce this patient for emergency surgery. Okay, very good, absolutely correct. So ketamine is the agent of choice in case of emergency surgery, and also whenever you want to induce anyone for rapid induction of anesthesia, okay, RSI, and when the patient is full stomach. Now why? There are 2-3 things that are important in this case. First thing is, all your IV anesthetic agents will cause a fall in the blood pressure. So your propofol, thyropenton, intermediate, everyone will cause a fall in blood pressure during induction except ketamine. Ketamine maintains or increases the blood pressure. So in this patient of splenic rupture, already because of blood loss there is hypotension, so you don't want more hypotension, so you will give ketamine. Alright. Second thing that we do is, patient is full stomach. So if the patient is full stomach, you want to prevent him from aspirating the food particles. So your ketamine maintains airway reflexes. What is the airway reflex that we are bothered about? Now, whenever I am drinking water, see this, when I am drinking water, the water is going into my esophagus and not into trachea. Why? When I drink water, the vocal cords close and the epiglottis shuts from top. So when these two things happen, the liquids automatically go behind into the esophagus. Nothing enters into the trachea. So this is the airway reflex that happens whenever I am eating or drinking something, which prevents the food or liquids from going into the trachea. So this airway reflex is lost under anesthesia. But if I give ketamine to the patient, then this airway reflex stays, and that is how I can prevent aspiration risk, or at least reduce aspiration risk in a patient who is full stomach for surgery. Okay. Alright. Now moving on to our next question. So identify all these agents and tell me what are they used for in anesthesia. Identify all these agents and tell me what are they used for in anesthesia. Very good, Hemal. So these are nothing but my inhalational anesthetic agents. Okay. So my inhalational anesthetic agents are used for what? They are used for maintenance of anesthesia mainly. Correct? Now you have to tell me which inhalational anesthetic agents are these and what is their MAC. So we'll write 1, 2, 3, 4. नीचे भी लिख रही हूँ 1, 2, 3, 4. So identify from the color of the vaporizer. This is the vaporizer. As you can see, vaporizer is the instrument which converts the liquid anesthetic into the vapor form. So identify from the color each of the vaporizers. Very good. Red is halothane. Excellent. Then first one is isoflurane, the purple one. Very good. Sevoflurane, second one, yellow one, very good. And 3, blue is, what is blue? Very good, Swapnil. So 3 is desflurane. Okay. So these are all my inhalational anesthetic agents. Quickly tell me the MAC of all these agents, because that is asked in the exam. MAC of the agents. किसी को याद है या नहीं? I have given a very nice video which gives you the mnemonic of MAC of all the agents. So if you all don't remember the MAC, you all can go through that video. It's just a 5-10 minute video on YouTube. Just put MAC mnemonic anesthetic agents and my name Jhanvi. You will find it. Bolo, bolo, bolo. MAC of these agents. Okay, I'll give you the MAC. MAC of isoflurane is 1.4, sevoflurane is 2, desflurane is 6 and halothane is 0.75. Okay? Now, again, just like we had all the other questions about the IV anesthetic agents, I'm going to ask you specific questions for inhaled anesthetic agents. So now tell me the inhaled anesthetic agent of choice for neurosurgery. The IV anesthetic agent of choice for neurosurgery was Thyropenton. Now tell me the inhaled anesthetic agent of choice for neurosurgery. What is the inhaled anesthetic agent of choice for neurosurgery? Bolo batao. Okay, now, yes, very good Swapnil. So, remember for three things, for neurosurgery, for cardiac surgery and for liver surgery, or if a patient has any problems in the brain, in the heart or in the liver, the agent of choice AOC is isoflurane. Why? Isoflurane maintains the blood flow to the heart, to the brain and to the liver. So as a result of this, we want to prefer isoflurane in neurocardiac and liver surgery. Got it? So we want to give agents that is the maintaining blood flow to all these diseased organs or the ones that are getting operated so that they do not deteriorate further. So the agent of choice will be all three of them. Alright. In all three of these surgeries will be isoflurane. Okay. Now, suppose I want to induce my patient with inhalational induction. So what is inhalational induction? Sometimes we have children who don't have IV lines in them. So instead of giving them IV anesthesia, because they don't allow you to take IV, they start crying and moving their hands. I hold the mask and I give them some anesthetic agent to breathe. Once they fall asleep with that anesthetic agent, I take an IV line in them. So this is one of the most important questions that comes in the exam. Inhalational induction is carried out with, preferably with which agent? Okay, Staphylococcus is saying halothane, desflurane, sub answers de diye. Okay. Yes, very good. So, the most preferred agent for inhalational induction in children is sevoflurane. And why does this happen? I'll tell you why. Because sevoflurane is very, very sweet smelling. Okay. So, when you smell the sweet sevo, the child falls off to sleep. On the other hand, if you give something which smells horrible, the child will not allow you to hold the mask on his face. So, for some amount of time, for literally 3 to 5 minutes, we hold the mask with sevo, the child smells the sweet sevo and goes off to sleep. And then we take an IV line and induce anesthesia in the child. Okay. Alright. Next question. Which agent, now I'll ask you 2-3 questions mixed together. So this agent causes bradycardia, it can cause autoimmune hepatitis and that's why it is not preferred to be used now. And it is used for, it causes a smooth muscle relaxation. So it causes 3 things. It causes bradycardia, it causes smooth muscle relaxation and it can cause autoimmune hepatitis. So what is the agent that I am talking about? Bolo. Anyone? Agent that causes bradycardia, it causes autoimmune hepatitis and it causes smooth muscle relaxation. No, not sevo. Very good, excellent. So it is halothane. Okay, so halothane, it causes autoimmune hepatitis and that is called as halothane hepatitis. So it was seen that when their obese females of middle age, around 40 years of age, were repeatedly having surgical exposure with halothane, at that time they were developing some antibodies against the liver. So that was labeled as halothane hepatitis. Okay, so halothane hepatitis is autoimmune hepatitis seen in middle-aged obese females. The second thing that we see with halothane is the presence of bradycardia. So it will act on your heart and it will cause decreased conduction of the rhythm, and as a result of this there will be bradycardia. And the third thing that it causes is smooth muscle relaxation. Okay, so because it causes smooth muscle relaxation, it is one of the best bronchodilators because it relaxes the smooth muscles of your bronchi. Okay, so it is a bronchodilator. It also relaxes the uterus, so that is why it can be used for internal or external version. Okay, now can you guys tell me, whenever we have halothane as the anesthetic agent, I would avoid it in which obstetric condition? If I have halothane, I would avoid it in which obstetric condition? So I've written a few things about halothane. I think you all are not able to see because I'm sitting in your line. So you all can watch it and then I'll come back to the place. But can you all tell me halothane is not used in which obstetric condition? Come on guys, I can see your answers. Fatafat type karo. Alright. So halothane is not preferred, or rather it is contraindicated in case of postpartum hemorrhage. Remember this. Why? Because in postpartum hemorrhage you want the uterus to contract so that the bleeding will stop. Okay, but in this case what happens is the uterus remains dilated, it remains relaxed, and that is why you have halothane hepatitis. Okay, now next question that I have for you guys is this. So in case of which of these agents is contraindicated in asthma? Now I told you halothane causes bronchodilation, so it is agent of choice in asthma because it helps in dilating the bronchi. But can you tell me what is the agent that is contraindicated in asthma out of all four of them? Agent contraindicated in asthma? Alright, so the agent that is contraindicated in asthma is desflurane. Why? Desflurane has a very pungent odor. So like how SIBO was very sweet smelling, desflurane is very pungent. So as a result of this, whenever you smell desflurane, you get this dirty smell, and the patient who is already asthmatic, the airways get irritated and there is more choking of the airways. So you can have more chance of bronchospasm with desflurane. So it is avoided in that case. Okay. Another one, which is the agent with the lowest blood gas partition coefficient? So you prefer this agent whenever you have obese patients or whenever you have short surgeries. So if I ask you, like I told you, the IV anesthetic agent of choice in daycare surgery was something which is very short acting and least metabolized in the body, that was propofol. So if I ask you what is the inhalational agent of choice in daycare surgery, what will your answer be? Inhalational agent of choice in daycare surgery. You want something which is least metabolized in the body, acts for a very short period of time and is quick in and quick out. Yes, so very good. So the agent of choice in daycare surgery is desflurane. Okay, why? Because it acts quickly. So action is quick to start and quick to end. So that is why we prefer desflurane. Alright. So these are the specific questions that they ask about all of these. Just remember, it's very easy. If they ask, mostly they ask what is the agent of choice for inhalational induction in children. That is one of the most important questions asked, and that is always sevoflurane. Okay? Okay, let's move on to our next set of questions. So, can you guys identify the class of drugs in this case? You have succinylcholine molecule over here. So, I'm just writing it, succinylcholine or scoline. Then you have vecuronium molecule over here and you have rocuronium molecule over here. So So can you tell me what is the class of drugs over here? Okay. Hemal, can you tell me the complete name of the class of drugs? What you're saying is absolutely correct. MR, but MR can be mental retardation also. Yes, so these are neuromuscular blocking agents, okay, or they are also called as muscle relaxants. Neuromuscular blocking agents or muscle relaxants, they are also called as muscle paralyzing agents, okay. Now, specific questions for you all. Obviously, which of these is the depolarizing neuromuscular blocking agent? सबसे simple वाला. Which of these is a depolarizing neuromuscular blocking agent, which is non-depolarizing neuromuscular blocking agent? Basic question. Yes, very good. So your depolarizing neuromuscular blocking agent is succinylcholine, and the non-depolarizing are all the other ones. Okay. So your VEC, ROC, ATRA are all non-depolarizing neuromuscular blocking agent. ये मैंने गलत लिखा है, non-depolarizing neuromuscular blocking agent. Okay. So now the next question comes is, before I give scoline to the patient, what is the serum electrolyte level that I need to check? So imagine I have to give scoline to my patient and I am just going through his file. I have literally 10 seconds to check the investigation. Which serum electrolyte level should I check before giving scoline to the patient? Yes, very good. So scoline is known to cause hyperkalemia. So I should always check the serum potassium levels before giving scoline. Second thing that they ask in the exam is, where all is scoline contraindicated? Okay, so remember, scoline is contraindicated whenever you have burns or whenever you have paraplegia or whenever you have any muscular dystrophy. Okay, so scoline would be contraindicated in all those three conditions: burns, paraplegia and muscular dystrophy. And obviously if there is high potassium levels, again scoline will be contraindicated. Okay, now where would I prefer scoline? So scoline being short acting, it acts for just like 9 to 14 minutes. Where would I prefer to use scoline? Give me any one condition in which I would prefer to use scoline. Any idea, anyone? One condition where I would prefer to use choline? Yes, very good. So in an anticipated difficult airway, I want something which acts for a short period of time. Why? If I am not able to intubate the patient, or if I am not able to put an LMA in the patient, then I will use choline for inducing that patient, so that the patient wakes up within 9 to 14 minutes and starts breathing on his own. Okay. So in any kind of difficult airway, if they ask you what is the muscle relaxant of choice, then my muscle relaxant of choice will be succinylcholine. Okay. Another thing, scoline acts rapidly. So if I want to rapidly induce a patient, and that is usually seen in rapid sequence induction, when I rapidly want to induce a patient with anesthesia, RSI, rapid sequence induction, I will prefer scoline. Alright. Now, in the non-depolarizing neuromuscular blocking agents, they have one-liners that they ask usually. So I'm going to ask you the one-liner, you have to tell me the answer. So, in case of renal or liver failure, what is my agent of choice? Which non-depolarizing neuromuscular blocking agent will I prefer in case of renal or liver failure? Fatafat. No. This is a very commonly asked question, guys. You cannot go wrong in this. Very commonly asked and very easy answer. Very good, Swapnil. Okay. So atracurium is the preferred agent whenever I have renal or liver failure. Why? Because atracurium has a special type of metabolism. It undergoes something which is called as Hoffman's elimination. So it does not get metabolized in the body. It does not get metabolized by the liver or the kidney. It gets metabolized in the plasma on its own. It is not dependent on any of the organs for its metabolism. So one agent that I will prefer if my liver is gone and my kidney is also gone and I know कि metabolism में problem हो सकता है, I will prefer to use atracurium. Okay. Now, what is the problem that I see with atracurium? I give atracurium to my patient and suddenly he has bronchospasm and he has hypotension. Why is this happening? I give atrac to my patient, sudden hypotension and bronchospasm. Is this normal with atrac? Is it abnormal with atrac? What is wrong with my patient? No, it's not because of acetylcholine blockade. Okay, so what happens when I give atracurium to my patient is simply that the atracurium causes release of histamine from mast cells. Okay, it's not abnormal, it is normal. It is an expected problem with atracurium. It causes histamine release from mast cells leading to hypotension. You can get rash and you can get bronchospasm. Okay, so this is a known complication with atracurium. Alright, so next question that I want to ask you guys is, what is the most cardio-stable non-depolarizing neuromuscular blocking agent? Most cardio-stable non-depolarizing neuromuscular blocking agent. So the one which causes least changes in the heart rate and blood pressure. So since there will be some problems in seeing, I am just moving a little bit. Very good, Swapnil. So it is vecuronium. Vecuronium is the most cardio-stable non-depolarizing neuromuscular blocking agent. Okay. Now the next question that they ask in the exam is, if my patient has scoline contraindication, okay, suppose he is hyperkalemic and he is coming for emergency surgery. Now I want to give him rapid sequence induction. I want to rapidly induce the patient with anesthesia, but I can't give scoline because potassium is very high. Then which non-depolarizing neuromuscular blocking agent will act rapidly? Which non-depolarizing neuromuscular blocking agent will act rapidly? Very good. So rapidly acting or preferred for RSI non-depolarizing agent is rocuronium. Okay, alright. Now, one of the questions that they used to ask previously, so I am just revising it with you all. What is the longest acting non-depolarizing neuromuscular blocking agent? बहुत पहले पूछते थे, I don't know अभी पूछेंगे या नहीं. Longest acting non-depolarizing neuromuscular blocking agent. Very good. So it is pancuronium. Okay. Nowadays we don't use pancuronium anymore because it causes severe bradycardia. But previously it used to be used, so that is why they used to ask this question. Okay. So the longest acting non-depolarizing neuromuscular blocking agent is pancuronium. One more question that they ask is, what is the shortest acting non-depolarizing neuromuscular blocking agent? So overall, if they ask you what is the shortest acting muscle relaxant, overall, okay, it will always be scoline, because scoline lasts only for 9 to 14 minutes. But suppose there is some contraindication to scoline and you cannot give scoline, and I want to give a short acting agent because my surgery is only for 20 minutes. So what is the shortest acting non-depolarizing neuromuscular blocking agent that I can give? All these are one-liners that come in your exam. They will simply ask you इसका आंसर क्या है, इसका आंसर क्या है. एंड it's like either you know or you don't know. You can't guess, or there is no guesswork in this, there is no elimination also in this. Either you know the answer or you don't know. So simple questions and you will be able to answer if you revise properly and go. No, rock and atra are not the shortest acting. There is one which acts for 15 to 20 minutes only. Any idea which one is that? Okay. Anyways, now you all can't see the below part, so I will tell you the answer. Very good editor. So it is mevacurium. Okay, so the shortest acting non-depolarizing neuromuscular blocking agent is mevacurium. So these are all the one-liner questions that they ask about muscle relaxants, which is specific questions about scoline, specific questions about the non-depolarizing agent, one-liners. Now, the last question that I want to ask you on this slide about the neuromuscular blocking agents is, which of these agents cause bradycardia? This is also one of the questions that's asked in the exam. Suppose I give you 4 options. Which of these agents causes bradycardia in the patient? Scoline, VEC, ROC and ATRA. What is the answer? Succinylcholine, VEC, vecuronium, rocuronium and atracurium. What is your answer? No, it's not VEC. Which agent causes bradycardia? Yes, very good editor. So it is nothing but succinylcholine. Okay. Now, how does succinylcholine cause bradycardia? So it basically goes on the SA node, and succinylcholine and acetylcholine are very similar looking, correct? So your vagus nerve that releases acetylcholine causes reduce in the heart rate, correct? So since succinylcholine looks similar to acetylcholine, the heart thinks, "Arey, ye to acetylcholine hi hai. So chalo, we'll reduce the heart rate." So the SA node reduces impulse generation. So as a result of this, there is bradycardia whenever you give scoline. Alright, so you have to be very careful. You have to keep your atropine ready so that if there is severe bradycardia, you can reverse it by giving atropine in the patient. So with that, we complete little bit of the revision of the short subject revision. Now, I did not get much time to explain to you guys what is this month's ka YouTube session going to be like. So I'm going to try and complete the revision of all the short subjects for you all. So we are starting off with anesthesia tomorrow morning at 11 o'clock. Also we have anesthesia class, and 10 o'clock also we have anesthesia class. So we'll be discussing the entire revision of anesthesia. After that radiology. After that we will be doing orthopedics and psychiatry and skin. Okay, so all 5 short subjects I will be revising for free with you all on YouTube. You just have to subscribe to this Telegram group. That's it. It's a free Telegram group. Please make sure you're there on this Let's Crack NEET PG, so that you get the links to all the YouTube classes. And 10:30 PM every day, as you all know, I am taking special classes on the special class platform on Unacademy. So there, those are again free classes where we will be doing flashcard revision of medicine every day. Alright, so hope to see you guys for tomorrow's class also, and we will make sure we complete good revision of everything before our exams. So thank you so much for joining me today guys, and I will see you next time. 10:30 PM today we have special class flashcard revision in medicine. Okay, alright, thank you so much guys, and I shall